I'm not quite sure how this works, but anyway, I'll read out the question, and then you just press the button. Okay, so the first question is, so a 30-year-old man is type 1 diabetic, he's got hypertension, he's got dose proteinuria and eGFR of 50. Which one of those drugs would you use to, as first line, treatment of blood pressure? So an ACE inhibitor, a beta blocker, calcium channel blocker, or thiazide diuretic. So did you just press your button?
Yes, there are right now. We've had about 50, 60 responses.
Okay. Okay. So just press forward, John. Okay. So that's right. So most of you got it about right. An ACE inhibitor. So remember what I said is that kind of heavier than pressure. If you've got dipstick proteinuria, usually that's a good reason for an ACE inhibitor, unless you've got evidence of vascular disease. Okay. So that's the correct answer. Okay. With regards to prevalence of CKD, I don't know if I talked about this or not, but anyway, with regards to prevalence of CKD, which of the following statements are true? Affects about 10% of people aged between 18 and 65. Affects about up to 30% of people over the age of 75. It's commoner in whites and on Caucasians. Most, I didn't write this actually, sorry, I don't know if you wrote this, most CKD, so CKD 4 and 5 are the commonest sort of stages in CKD. Most CKD patients have CKD stage 4 and 5. Yeah. Okay, see if you understand. It doesn't. Okay. So, yeah, it's going to be right. So basically CKD is very common in the elderly. So basically CKD effectively is a disease of the elderly. And so up to 30% of people, or prevalent people in your practice over the age of 75 will have label of CKD. So that makes me think there's something wrong with the definition of CKD, because it might be that we're just basically labeling people who are elderly as having the disease. But anyway, that's the word. That's for another day. Okay. So yeah, the correct answer is that 30% of people over 75. Okay. If you take 100 patients with CKD 3, what percentage will need dialysis or a transplant within 5 years? Okay, so I'll stop that. So, yeah, so you got that right. So the key thing to remember is that actually, in fact, it's probably less than 1% actually, but very few people with a label of CKD 3 will end up on dialysis, right? And also elderly CKD 4 patients. It's a very, very rare outcome of CKD. Okay. So the correct answer is 1%. So this is another way of looking at it. So if you take 100 patients with CKD 3, what percentage will die within 5 years before, if you like, they need dialysis or a transplant? I can't remember the answer to this myself. So it's around, yeah, it's a bit higher. So remember, CKD is really a marker of vascular disease, really, because if you think about it, the kidney is just made up of lots of blood vessels. So if you have cardiovascular disease, then you just have, you're very likely, a lot of people, the heavier the cardiovascular burden, if you like, the more likely you are to have normal kidney disease. So it's a bit higher than 10%, it's about sort of 25% is the correct answer as well. Okay. So this will be the point, but then finally, so which of the following is the commonest cause of CKD, commonest cause of death in patients with CKD? Kidney failure, cardiovascular disease, cancer, infections, or anemia? By kidney failure, I mean those who need dialysis or replacement. Six. Okay. Yep. So they're all dying from heart disease. Okay. So which of the following statements regarding statins are true in CKD? They're nephrotoxic, so you should avoid. They slow down the decline in kidney function. They reduce the risk of death. They reduce cardiovascular events. Increase risk of deranged diabetes. Is it right? Okay. So I think you all got the right answer there. So just one thing to remember, because obviously a lot of people get quite worked up about statins because a lot of people get side effects, a lot of people get side effects. So the only thing that statins do really is, in the context of chronic kidney disease, is reduce the risk of cardiovascular events. But the number needed to treat is about 1 in 30 to 1 in 40 at 5 years. So if someone gets bad side effects, I don't think you need to get too kind of worried about it really, because for that individual patient, it may not make that much difference, to be honest. So, this is a state case scenario. So this is a 70-year-old man who's a smoker, who's got peripheral vascular disease, he's diabetic and got hypertension. He's got CKD4, he's got, on his urine dipstick, he's got no blood and no protein on the dipstick, but he has slightly increased ACR, so he's got microalbuminuria. What's the likeliest cause of his CKD? Okay. Okay. So this is good. So this is a good question, because one of the things I said in a very rushed way in the lecture was that you needed to have proteinuria. If you're diabetic and you think someone's got diabetic kidney disease, they've got to have proteinuria. Okay. And microalbuminuria is very low level proteinuria. Okay. So I told you the urine dipstick is normal. So if the urine dipstick is normal and you've got GFR of 29 or less than 30, then you've got very advanced kidney disease, and therefore you would, if it was diabetic nephropathy, you would have significant proteinuria in the 1+2% dipstick. Okay, so it's very unlikely to be diabetic kidney disease because they've got no proteinuria, no significant proteinuria. Plus they've got all these risk factors for ischemic nephropathy, so they've got peripheral vascular disease and they're a smoker, and of course they're diabetic, which of course increases the risk of vascular disease as well.
So that's more big vessel regardless of small vessel?
I don't think so, because I think if you think about it, you're also you've got a renal artery that's obviously a big vessel, but actually if you think about the kidney, it's made up of lots of glomeruli, which are actually just small blood vessels actually. So, and diabetes is a disease of small blood vessels as well, but it's the lack of proteinuria that is the key factor there. So if you had retinopathy and if you had or if you had increasing proteinuria, so his ACR was kind of 1 10 years ago, 12 3 years ago, now 35 40, that's much more consistent with diet properly. Okay. Any questions about that? No. Okay, so which one of the following conditions does not need regular CKD surveillance? So these aren't necessarily patients. These aren't patients with CKD, but these are patients who you need to monitor their kidney function for. Yeah, okay. So, yeah, COPD. So, some of the prostatic, yeah, so I mean, if you've got kind of prostatic disease, I think you definitely do need to have your kidney function monitored, maybe just once a year. So if you're taking non-steroidals chronically in gout, then you definitely need to have your kidney function monitored. So, a 60-year-old man who's got stable CKD3 with an EGFR of 35, he smokes, he's got angina, he's got gout, and he's got peripheral vascular disease. Which would be the best drug first line for his blood pressure? An ACE, an ARB, a calcium blocker, or direct renin inhibitor? Are we all right tonight?
Yeah.
Okay, I think I'll sort of. So there's a bit of a kind of so 37% of people went for an ACE inhibitor, and 56% of people went for a calcium channel blocker. I mean, my answer would be C, which would be a calcium channel blocker, because I think this gentleman's very, very likely to have peripheral vascular disease, renal vascular disease, because they've got peripheral vascular disease, they're a smoker, and therefore, I think if you're going to use an ACE or an ARB or a direct renin inhibitor, then you're going to have to monitor their kidney function very slowly. So personally, to kind of make life easy, a calcium channel blocker would be much better. And remember, it's much more important to have, it doesn't really matter what tablet you're taking, it's far more important to have good blood pressure control. The tablet doesn't really matter usually that much. So my answer would be D. And why wouldn't we use a thiazide? Probably because he's got gout. Okay. Sorry, this is a complex question. So which of the following can be nephrotoxic? Trimethoprim, ibuprofen, metformin, sulfasalazine, lansoprazole, B and D, so that's ibuprofen and sulfasalazine. B, D and E, sorry, I'm not guilty on this question, which is ibuprofen, sulfasalazine and lansoprazole, or all of them. It's quite complex questions because there's so many options here. Yeah, that's it. Okay, so it's actually B, D, and E. So let me just go through this. So trimethoprim isn't nephrotoxic. Okay, so trimethoprim, if you put someone on trimethoprim, their creatinine will go up because it blocks the secretion of creatinine. Okay? As soon as you stop the trimethoprim, a week later, the creatinine will go back to baseline, so it's not nephrotoxic. Ibuprofen, you all know, I think, is nephrotoxic. Okay? Metformin is not nephrotoxic, so metformin increases the risk of lactic acidosis, and that risk is increased if you've got CKD, but it is per se not nephrotoxic. It doesn't affect your kidney function, and it just makes you more prone to getting kidney disease. The only reason why you stop it is because it increases your risk of lactic acidosis. Sulfasalazine and lansoprazole can both cause a sort of an interstitial nephritis, so an allergic interstitial nephritis, and so they're both potentially nephrotoxic. Okay. Yeah, it's PPI condition. So that's quite a rare complication of having a PPI. But I'd say we probably see maybe one person a year who has acute kidney injury secondary to PPI. So it does happen. And of course, also millions of people have got CKD, and millions of people have are on PPI. So actually, it might be the core. I don't know how it's difficult to disentangle how many patients have CKD as well as PPI. Okay. So which of the following can cause microalbuminuria? So just remember, microalbuminuria is dipstick pressure, is when your dipstick is normal but your ACR is elevated. So diabetic nephropathy, Crohn's disease, poor dental hygiene, chest infection, diabetes and poor dental hygiene, or all of the above. Oh, sorry, this is not teaching anyone. Yeah. So basically, it is actually all of the above. So the thing about diabetes, one of the problems with urinary is why I obviously like the sort of fact that you have to monitor an ACR and someone's got negative urine dipstick. So anybody with any kind of acute illness, all right, can have low-level pressure urea, so microalbuminuria. And so it may be a marker of kidney disease, as in diabetes or hypertension, but you can get it in any inflammatory state or any infected state, really. So it's a bit like, an old colleague of mine used to describe it as a bit like a urinary ESR. So ESR is a fairly kind of useless test, and it's a bit, in the sense it doesn't really tell you very much. And it's a bit like a urinary equivalent of an ESR. It just tells you something's not right, but it doesn't tell you what. So all those are associated with microalbuminuria. So be very careful about interrupting microalbuminuria. So next question about ACE inhibitors. So which of the following statements with regard to ACE inhibitors, is true? Should prescribe to all patients with CKD, first line in all hypertensives, most effective in the elderly and the Afro-Caribbean, most benefit if you've got increasing proteinuria. Okay. Okay. Yeah, that's exactly right. So remember, increasing proteinuria more likely to benefit from an ACE inhibitor. It's certainly not. You certainly don't give it to everybody with CKD, okay? And it's certainly not the first line in all hypertensives, okay? And actually, if anything, it's probably less effective in the elderly and the Afro-Caribbean. Okay. So we've now. Has anyone got any questions about the MCQs? Okay. So we've now got some time to maybe do some. How many have we got? So we've got 20 minutes. So we'll just see how we get on. First one. So this is a guy with hypertension and congestive cardiac failure, aspirin, atorvastatin, amlodipine, and ramipril. His EGFR is 38, and that's stable. His urine dipstick is negative, but his ACR is elevated, so his ACR is 20 milligrams per millimole. Okay, so he's got what's called microalbuminuria. Okay. Does anyone want to hazard a guess as to what his under the new NICE classification system, what category of CKD he has? So remember, there are 5. There's G1 to G5, which is the same as the previous. So he would. G stands for GFR. So his G would be G3 what? B. 3B. Yeah. Okay. And then you have to define albuminuria, which is A1, A2, or A3. A1 is normal. A3 is if the dipstick is positive, which is usually when the ACR is greater than 30, and A2 is somewhere in the middle. So what would he have? So he'd have A2. Sorry, it's not a very useful clinical decision aid really, but this is just on the classification. So he would have CKD. He would have G3A. and sorry, G3B, because G3B, A2. So yeah, so he would have there and there. Okay. No. Yeah, so if you read the red guidelines, it doesn't necessarily, the guidelines for referral aren't the same as the guidelines for red, so it needs the appropriate management. Yeah? So the guidelines for referral are slightly different from the RAG rating. Okay, so 75-year-old lady who's diabetic, who's hypertensive, is a smoker, recently moved to your practice. The blood pressure is 150/90, and the EGFR is 26. And this is a report, but hopefully this doesn't happen anymore. But it used to happen in the early days of GFR. So it says severe kidney disease referred to CKD guidelines. So, and the creatinine was 150 in 2007. Okay. So, what do we think the likeliest cause of this? Well, what are the possible causes of this person's kidney disease? So it could be cardiovascular, yeah. Could be diabetic, because we haven't told you anything about the proteinuria. So someone said it could be diabetic, and that's absolutely right. So it could be cardiovascular because he's a smoker, or she's a smoker, and it could be diabetic, okay? What do you think about the progression? So in 2007 the creatinine was 150, and now it's 180. So in my mind, that's pretty slow progression, really. I mean, obviously it's progressing, but over the last 7 years, you've lost 30 micromolars of 30 micromolars per litre of creatinine, so that's not a lot. And so although the CKD guidelines would therefore say you should refer this patient to secondary care, actually there's probably not a lot that this patient needs to do because they're 75, and by the time they get to an EGFR of 10, they'll either be 100 and something at this sort of rate of decline, or they'll die of something else, and that's what usually happens. Okay. So what would I do? What would you do next? Yeah, so I think all you want to monitor and see if you can maybe get the blood pressure a little bit better than it is really. So this is what I would do. Tell the patient she's got very stable CKD. Focus on blood pressure control. If they've got a heavy proteinuria, you could try and NACE or an R with electrolyte monitoring. If you're not sure what to do, you can write to us. Okay. So next lady, this is a 93-year-old lady. Oh, sorry, yeah.
You probably already do, but if you get slightly scared, patients who are a bit worried about that, the graphs that you've already sent are quite useful, because they can see that they're not going to hit the dialysis level until they're about 130.
Yeah.
So.
Yeah, that's right. I think basically, the nice guidance basically effectively made CKD an age-neutral disease, and that's kind of a fundamental flaw, I think, in its personally in its kind of approach. Because we all die as we get older, but not only do we all die, but obviously every bit of our body doesn't work as well. Do you know what I mean? So it's not really. So that's a fundamental problem with that system. Okay, so the next case is a 93-year-old lady who's frail and she's diabetic and she lives in a nursing home and she's had a recent BTI. Her creatinine was 130, and then 3 months later you remeasure it and it's 170. You can't get a urine dipstick. Her blood pressure is 140/70. So a slight increase in her creatinine over a short period of time. She's frail and her blood pressure is that much. What would you do next? Sorry? Just look after her, make sure she's going to do that. Yeah, that's exactly right. So that would be my thought. I mean, I have had a couple of, we get referrals like this, believe it or not, quite commonly. Sometimes people manage to do ACRs as well. And the ACR is usually elevated mainly because patients, when they're frail, their urine creatinine is very low because they don't have a lot of muscle mass, so that ACR is automatically elevated. But that's the common sense answer. That's exactly what I would do. I would just talk to the family and patient and just say we don't really want to do anything. The easy things you can do are review the medications, just to make sure there's nothing nephrotoxic that they're taking. And depending on their wishes, the only other thing, if their kidney function continues to decline, depending on their wishes, they might want to do an obstruction, because that might be potentially depending on the cause of obstruction, might be quite easy to treat.
Comment, please.
Yeah, one quick question. Is there an age where everything else being well, you would take as a cut-off point for analysis?
It's all to do with functional status.
Dala is a good 90-year-old.
Yeah, we've done this 90 years. It's all to do with functional status, I think. Okay. So next one, so 78-year-old female hypertensive diabetic ex-smoker with peripheral vascular disease. The urine dipstick is negative for bone protein. Blood pressure is 150/90. EGFR last year was 35. It's now 28. In view of progression of kidney disease, please can you see? The patient's on aspirin, simvastatin, Ryoprol, and benfluoreside. So, is there anything anyone would do here? Or first of all, maybe the first question I should ask: what do you think the likeliest cause of their kidney disease is? Yeah, it's probably more likely to be vascular, isn't it, than diabetic, because they've got advanced kidney disease. So the GFR is 28, and they've got no protein in their urine. Okay, so it's unlikely to be diabetic. Okay, so you can certainly refer to it as. What's the other thing you possibly could do? So you could stop the run. Okay. Which is a reasonable thing to do. What do you think about the benfluoreside? So the only thing to remember about thiazides is that they're not particularly effective, as effective when your GFR drops to less than 30. So if your EGFR drops to less than 30, you might want to switch them to a loop diuretic like this one. So this is what I would do. So there's no real nephrological reason for them to be on the NACE. They've got a high risk of renal disease, so I would stop the ACE inhibitor. There's a high risk of cardiovascular death, so I put them on aspirin or statin. They're already on aspirin or statin, and you may want to switch their diuretic. And if the EGFR continues to decline, then obviously it makes sense to come to us, but quite often the EGFR will improve. 75-year-old type 2 diabetic is a non-smoker. His GFR was 60 and 40. These are all real cases, by the way. GFR was 60 and is now 48. He's got 1 plus of protein in the dipstick, an ACR of 25. He's got good blood pressure control. I'm not sure why his kidney function has deteriorated, and I'd be grateful for you to see the patient. So it's gone. So the 1 blood test 6 months ago, which was 60, and in that repeat blood test was 48. He's otherwise very well. Anyone do anything different? Yeah, I think that's right. So that's so I think the problem is with the EGFR or creatinine is that it's very fluctuant, really, particularly at this kind of level between 50 and 70, and that could just be part of your normal variation depending on what is eaten the day before. So you just don't know this is progression, really. So I think to say someone's got, I mean, clearly if he was acutely unwell, that was probably very real, but if he's completely well, which he is, that's probably not real deterioration. So the first thing to do is to probably repeat it a couple of times, really, to make sure it's progression. And then if it continues, so you repeat the creatinine a few times to make sure it's progression or not. If it persistently deteriorates, then I probably would do a ultrasound, because I think in someone that age, obstruction must be, with a negative dipstick, must be quite high on the list of possible causes. And then you monitor CKD as you would do. I think this is the final case. I think it's not the final case.
Yeah, thank you. There was more. We've got 6, we've got 3 more.
Oh, we're nearly done. Okay, so we should be, are we all right for time?
Yeah.
Okay. So 72-year-old lady who's type 2 diabetic. She's got diabetic retinopathy and ischemic heart disease. Her last 2 EGFRs have gone from 36 to 29. Last year her EGFR is 47. Her ACR is 150, so she's got heavy proteinuria, and her blood pressure is high. And she's on lots of pills. What would you do? Sorry?
Stop metformin.
Stop metformin, okay, yeah.
Stop running.
Okay, well, I think the problem with stopping round is that, well, what do you think the cause of this lady's kidney disease is? So it's going to have diabetic retinopathy, and I've already told you that the heavier the proteinuria, the more the benefit of an ACE inhibitor. So I personally wouldn't stop the round run.
How about an ARB?
There's no difference between the two.
Can I just ask, in
The case study 4, I'm sorry for being ignorant, it was a gentleman with vascular kidney disease whose EGFR dropped to below 30, and the consensus was stop the ACE. In this lady, obviously her EGFR dropped just below 30, but it's a diabetic kidney disease. Is that why you suggested the ACE?
So I would, because basically in case 4, the patient had no proteinuria. Okay, so the benefit of an ACE inhibitor is very limited. All right, so you have nothing to lose. In this case, the patient's got a lot of proteinuria, irrespective of whether they're diabetic or not. The benefit of an ACE inhibitor is likely to be greater. So I think what's the single most important thing probably to do with this patient? Refer. Did someone say refer? Yeah. Because this patient's got really rapidly progressive kidney disease because their GFR's nearly halved in the last year. They've got really heavy proteinuria, so you know they're going to keep progressing. Okay? So someone like that, I think kind of referral is the key thing. And this patient's got bad diabetic nephropathy. And, you know, on that trajectory, she'll have a GFR of about 13, 14 next year. Okay? And the other clue that this patient's got diabetic nephropathy, as well as her proteinuria, she's got retinopathy as well. Okay. And she's got all the high risk factors: diabetes, proteinuria, poor blood pressure, and referring to us as important. And I've already said stop the lactic acidosis. So I've given 3 or 4 cases where you have a couple of different type 2 diabetics, same age, roughly the same EGFR, and some need referral and some don't, some need stopping the ACE inhibitors, some don't. So it's all dependent on clinical context, I think. I think this is the last one, is it? Okay. 71-year-old obese man. He's hypertensive, insulin-treated diabetic, bad blood pressure, EGFR not too bad, of 50 mils per minute, platinum of 130, an ACR that's high. Please could you see with regard to his proteinuria? Okay? And he's on a tiny dose of ramipril. So, what are the possible the first question is, what are the possible causes of this man's proteinuria? Yeah?
Diabetic nephropathy.
So he could have diabetes. Is there anything else that can cause bad proteinuria? Infection can, I don't think he's got infection. Blood pressure, so bad blood pressure causes proteinuria, and actually that's one of the reasons why actually controlling blood pressure is sort of come mainstay of CKD, so management. So he's actually got 3 reasons why he might have bad proteinuria, which is he's a diabetic, he's also got basically poorly controlled hypertension, and he's the third thing which you may not know, but if you're morbidly obese, which obviously increasingly we see a lot of patients who are morbidly obese, then obesity itself can cause proteinuria. So, and he's not really on any significant antihypertensive medication, he's just on a tiny dose of ramipril. So I think in this situation what I would do is try and get the blood pressure, at least try and titrate up the ramipril, maybe add in something else. If the proteinuria doesn't improve, then I would refer. But I think what you probably find in this situation is that, in fact, what we did find is that proteinuria, as soon as you control the blood pressure, proteinuria will improve quite dramatically.
How soon after increasing the dose of ACE or whatever does the proteinuria
It can improve within a week or 2. It really just depends on the blood pressure. If the blood pressure improves, then the proteinuria will get better, usually. Okay. So that's what I do. All those 3 things can cause proteinuria: hypertension, diabetes, and obesity. And you just want to try and control the blood pressure before worrying about the ACR too much. So thank you. I think that's it. Thank you very much.